The topic of my report is polynucleotides application, experience of enteropathy among osteoarthritis patients after myocardial infarction. The research was carried out on the basis of the internal disease department of medical.
Dr. Elena, I'm sorry again for interrupting. Please give slideshow and move your slides simultaneously. We could see only the first slide.
Oh, I'm sorry.
And now?
No.
No.
You will see the slideshow option at the bottom of your PPT. Or can we share the screen on your behalf?
Mm-hmm.
I think this. Can you see now?
Yes, we can see it, but not in a slideshow mode.
And now? And now? So
No.
in slideshow.
Yes, please click on it.
Let me check once again. Sorry. And now?
Yes, perfect.
Mm-hmm. Scientific fields of the internal disease department, aftercare, regenerative medicine, preventive medicine, clinical pharmacological research, epidemiological research. Therapy of osteoarthritis, a disease which affects not only joint but also particular structures, causes difficulties among doctors of all specialists who deal with this problem. While osteoarthritis progression, pain becomes intense and bothers patients both moving and rest. It is important to identify the patient's source of pain and carry out a deep clinical research before applying local therapy. Osteoarthritis patients have a lot of comorbidities. The most common are arterial hypertension, atherosclerosis, ischemic heart disease, diabetes, obesity, and others. These diseases connect with one another pathogenetically and affect every pathologic process. Therapy with all possible methods of osteoarthritis treatment, including local injection therapy, especially among comorbid patients, is a necessary means of aftercare and smart activity of those patients affected course and prognosis of other disease, cardiovascular ones of particular. Hypodynamia caused by pain in an affected joint can lead to worsening of cardiovascular symptoms. Features of osteoarthritis cause which cardiovascular pathology. Impaired circulation in patients with CHF and low-level inflammation resulting in faster destruction of joint tissue and speed up generative change in cartilage and secondary bone. There is damage of such particular structures and tendon, arthritis, bursa, and affected joints. It is known that combination of osteoarthritis and other morbid condition has much less favorable prognosis in comparison with any other particular nosology. Effectiveness is safety. Osteoarthritis on the basis of cardiovascular pathology needs special treatment approach. It is necessary to restrict taking traditional drugs such as NSAID and local glucocorticosteroids due to possible progression on arterial hypertension, coronary artery disease, and chronic heart failure. The problem of drug therapy, while multimorbidity being discussed lately, has found a general opinion of medical community treatment effectiveness should neither prevail over safety nor lead to exacerbation of comorbidities. A local treatment of osteoarthritis. What's new? Traditionally, glucocorticosteroids, hyaluronic acid, chondroitin sulfate were used for interarticular and biarticular injection, but with the development of molecular biology and clarification of osteoarthritis pathogenesis mechanism, new ideas for usage to non-trivial treatment methods have appeared. Nowadays, the arsenal of medication for local osteoarthritis therapy has been extended by again on polynucleotide basis. The medication chronotron representing health based of polynucleotides was applied in real clinical practice among osteoarthritis patients. Chronotron has been patented in Italy as an injection composition of polydeoxyribonucleotides for osteoarticular disease treatment. It contains the mixture of polynucleotides with molecular weight from 50 to 1,500 kilodalton received by sterilization and high degree purification of rainbow trout and chum salmon meals. Active protein and peptides absence prevent from immune reaction while using the medication. Preferred serum contain 2 ml chronotron gel with active substance concentration of 12 milligrams in milliliters. What are polynucleotides? What is their principal difference from traditional medication? Polynucleotides. Influence of regeneration and inflammation. Polydeoxyribonucleotides are DNA fragments with low molecular mass, substance of natural origin, which can reduce inflammation, stimulate protein matrix synthesis, cell growth, and migration. Fulfilling their regenerative potential, polynucleotides can have antipoptotic and anticatabolic effect in musculoskeletal system tissue. In vitro conditions, there have been received some data about polynucleotides' influence of increased production of anti-inflammatory cytokines, interleukin-10, which had reduced stimulated inflammation. Action mechanism of polynucleotides. Polynucleotides are known to stimulate macrocirculation, cell regeneration, DNA reparation with simultaneous inhibition of apoptosis and matrix metalloproteinases activation. Production of stimulation of interarticular matrix proteins, fibronectin, and collagen provide effect of saving an array of connective tissue structures when using polynucleotides. In scientific literature, there are some data about pain and inflammation reduction when using polynucleotides due to activation to adenosine A2A receptors. Advantages of natural polynucleotides. It's a natural biomatter containing fragments of DNA which is close to human DNA. Getting into tissue does not inflammatory of immune reaction, absence to allergization and immunogenicity, decomposes to oligo and mononucleotides. Nucleotides and nucleosides bind to A2A receptors. Anti-inflammatory effect is realized via A2A receptors. Regenerative effects are prolonged. Therefore, the action of polynucleotides extend for indefinite period of time depending on regenerative potential of a macroorganism. On research, 12 patients with high comorbidity index, 5 male and 7 female, average age of 42 plus minus 4.6, diagnosed enthesitis and enthesitis besides, and part of osteoarthritis, experienced local injection therapy using 2 ml chronosome twice with 10 days interval. All this patient had been treated locally with betamethasone. The last administration had been carried out 6 months before. Local pain was determined while clinical examination. Some patients had a swelling in pads in the rhinoceros foot area. Ultrasound examination revealed blood contour of tendon structure, thickening, reduced echogenicity, pain when pressing with sensor. While working, the patients felt increased pain, which led to motor activity decline. Pain objectification was determined according to visual analog scale. Before treatment, it was 78 plus minus 5.8 millimeters. The feature of enteropathy pain is a poor response to a systemic analgesic therapy. Effect of polynucleotides for enteropathy. In intracerebral injection, usage of polynucleotides will have an additional positive effect of ligamentous tendon apparatus in connection with proved influence of increased production of some growth factor, vascular endothelium growth factor, and fibroblast growth factor, stimulating angiogenesis and reparation of affected connective tissue fibers. Angiogenesis improvement was proved by increase of CD4130, transglutaminase 2, and angiopoietin. Injection were carried out under ultrasound navigation. Pain syndrome among patients decreased by 43 plus minus 2.6% after the first injection and 74 plus minus 6.2% after the second one. Now, the patient refused the injection because of poor tolerance of medication of subjective general condition deterioration. In 6-8 weeks at follow-up appointment, the patient had neither complaint in local soreness nor reduction of motor function due to pain along knee joint middle surface. Cardiovascular safety assessment method. General clinical, instrumental, and laboratory methods were used for therapy safety assessment. Blood pressure management and heart rate data were recorded in an individual diary. ECG monitoring on the day of injection. Study of lipid panel, CRP level, and uric acid before and after local injection therapy. Also, patient recorded cases of chest pain, dyspnea, dizziness, heartbeat, and arrhythmia in the individual diary. Subjective assessment of polynucleotides, portability, and effectiveness. According to subjective patients' assessment, portability of chronotron treatment by verbal scale, perfect, 16, 57% good, well, 43%. Result of using chronotron according to patient's assessment, influence of pain on pain, joint function, general motion activity, perfect, 12, 43% good, 14, 50% satisfactory, 2, 7%. According to research results during polynucleotides local injection therapy, no patients had tendency to increase in systolic blood pressure and diastolic blood pressure on the day and the day after intraarticular injection. Average level of systolic blood pressure in test group was 180 or 4 plus minus 4.8 millimeters of mercury. Diastolic blood pressure 78 plus minus 3.1 millimeters of mercury. A lipid panel and uric acid level in blood did not change. According to ACG data, arrhythmic events were registered in 5 patients on the day of injection. In 2 cases, ventricular extrasystole of second gradation by alarm valve without hemodynamic disorders. In 3 cases, ventricular extrasystole without hemodynamic disorders. Ischemic events were not registered. Attack of angina pain were not registered after chronotron injection. Advantage of using polynucleotides in clinical practice is not only a longer therapeutic effect in comparison with a quick short-term effect of GCS, glucocorticosteroid, but also absence of a number of complications: local trophic, osteonecrosis, resorptic effect, associated with carbohydrate metabolism destabilization, blood pressure, water and electrolyte balance, bone metabolism, hypocoagulability, and other. High safety and perfect portability of chronotron are explained by its composition. Polynucleotides in natural molecular have natural origin, don't possess toxic effect, while enzymatic digestion of polynucleotides, nucleotides, and nitrogenous bases are produced. Medication contain DNA fragments with low molecular weight, particular original drug for intraarticular injection chronotron received from rainbow trout mills by high degree purification and sterilization to decrease immunogenicity have been perspective of usage. Due to provide high safety and multi-vector pharmacological effect, especially in situation where the drug intolerance or resistance to treatment with other medication. If there are any question, I will gladly maybe. Always ready for cooperation. Thank you for your attention.
To present our medium-term results of the Ascension Pyrotitan surface replacement and pyrocarbon hemiarthroplasty in the shoulder. I'd like to acknowledge the co-authors, Ian Penny, who is a Christchurch orthopedic surgeon. This is basically a summary of his and my cases, and also Chris Frampton, who's the statistician for our New Zealand Joint Registry. So firstly, what got me interested in pyrocarbon, and then I'd like to present a summary of results of both the Ascension Pyrotitan surface replacement and the pyrocarbon hemiarthroplasty. Is wear a serious issue with pyrocarbon? And I'll present some clinical cases. So why pyrocarbon? By 2010, I've been in practice for 20 years, and it was clear glenoid loosening was a major issue in young patients undergoing anatomic total shoulder replacement. So how do we manage difficult problems like this? This is a 20-year-old male who underwent high-dose steroid treatment for leukemia at the age of 16, resulting in avascular necrosis of both femoral and humeral heads 1 year before. You can see the collapse of the subchondral bone, and on the MRI, quite a serious problem for a 20-year-old patient. Another case, a 44-year-old engineer and tandem skydiving instructor who fell 10 feet to the ground when his canopy collapsed. He sustained a fractured pelvis and anterior fracture dislocation of his left shoulder, complicated by AVN. The axillary lateral shows the dislocation, partial dislocation. In 2010, the first Ascension Pyrotitan surface replacement was implanted, and with its very low wear rate against native bone, it looked an exciting prospect. In early 2011, Ian Penny and I visited Mark Ross in Brisbane. He's a meticulous surgeon, and we've got a good grounding in how to put this implant in. So what was our experience with the Ascension Pyrotitan surface replacement? This was first implanted in New Zealand on the 2nd of September 2011. We implanted 21 before. In August 2013, it was withdrawn from the market in New Zealand due to a 2.9% fracture rate. This is a patient who presented 43 months following surgery with pain and bruising down the arm, rupture of the long head of the biceps, and squeaking inflection. And you can see the fracture of the pyrocarbon in this region here. And at revision, that was the appearance. Those were the fragments of pyrocarbon, so not a happy situation. Pyrocarbon hemiarthroplasty, which is never fractured, was first implanted in Lyon in July 2013. I think it was planned to be Gilles Walsh, but he was at our shoulder and elbow meeting in Queenstown. I joined a limited user release group, mainly European surgeons, some Australian surgeons, to work on the project. Cases and instrumentation were discussed. And importantly, we established the need for larger than 50 millimeter heads, which was the largest available at the time. So in this series, we inserted 21 Ascend Flex 51 pyrocarbons. Of 21 pyrotitan implants, 3 patients were deceased. 1 patient fell 6 weeks post-op, sustaining a major cuff tear, and at 2 years required revision to reverse arthroplasty for persisting pain. 1 implant fractures at 43 months and was revised to an Ascend Flex pyrocarbon hemi. 1 required open repair of subscapularis and included this was included in the study group. This left 16 for follow-up assessment. Of the 58 pyrocarbon hemiarthroplasties, 2 patients were deceased, 2 were revised to reverse total shoulder replacement, 1 for cuff failure, 1 for Cutibacterium acnes infection, common problem in the shoulder. This left 54 for follow-up assessment. Overall follow-up, we had 100% follow-up of the 70 patients with pyrocarbon implants. The pyrocarbon surface replacement, we followed up at an average of 8 years and 2 months, and hemiarthroplasty 5 years and 2 months. Age at implantation on average was 57.7 years, but quite a wide range from 20 to 80. The majority of these were male, 56%, in contrast to shoulder replacements in our registry, where only 38% were male and the majority female. Etiology was by far and away most common in osteoarthritis, 56 patients, post-instability, 10 patients, post-fracture, 7 patients, AVN, 4 patients, and 1 each of synovial osteochondromatosis and rheumatoid arthritis. This is just a comparative series, a meta-analysis of 536 patients, comparing the etiology with the etiology in our situation, and basically fundamentally fairly similar. For patient assessment, we utilised Oxford scores. This was for ease of comparison of the data with our New Zealand Joint Registry, where the standard score is the Oxford score. We also looked at the subjective shoulder value developed by Christian Gerber. What is the overall percent value of your shoulder if a completely normal shoulder represents 100%? We also had patients experience squeaking, and if so, how often? In our results, the pyrotitan surface replacement at 8 years and 2 months, 88.9%, was still in situ. Of the pyrocarbon hemiarthroplasties at 5 years and 2 months, 96.4% were in situ. The survivorship curves show that most of the failures occurred relatively early, with fairly stable results out to 8 or 9 years. Subjective shoulder value, the pyrotitan surface replacement 87%, pyrocarbon hemi 86%, combined 86%. Oxford shoulder score, pyrotitan surface replacement 42.25, pyrocarbon hemiarthroplasty 41.89, and combined 41.97. The age of distribution, you can see the majority are between 50 and 70, but quite a wide range overall. Interestingly, if you looked at those over the average age, 57.7, Oxford scores were 43.8 compared to 39.7 for those younger than average, and the p-value here was 0.027. Similarly, with the subjective shoulder value, those over the age of 57.7 had better results than those below 57.7 with a p-value of 0.005. Oxford scores by diagnosis, did that make any difference? Well, post-instability arthropathy did the best. 44 was their Oxford score. Osteoarthritis, 42.6. Post-fracture, not so well at 39.5. And lowest avascular necrosis at 35. The numbers were such there was no statistical difference between these. We then compared the pyrotitan surface replacement with a comparable cobalt chrome surface replacement in the global cap. And this is data from our registry. You can see the 6-month Oxford score for the pyrotitan was 39.9 and 45.7 at 5 years. At 6 months, the global cap was 34.5, and at 5 years, 39.5. That was a statistically significant difference at 0.005. We then compared the pyrocarbon hemiarthroplasty with a similar Aqualis cobalt chrome hemiarthroplasty. This was our current series compared with registry data. You can see at 5 years, the pyrocarbon scored well at 42.2. The Aqualis cobalt chrome not so good, 36.6 with a p-value of 0.003. Comparing the Oxford scores for different arthroplasty types, you can see that the pyrotitan surface replacement and hemiarthroplasty are up there with total shoulder replacement and with resurfacing, and well above hemiarthroplasty with its cobalt chrome head. Of 70 patients, 14 reported squeaking, or 20%, 4 on a daily basis, 5 on a weekly basis, 5 on a monthly basis. The Oxford score for squeakers was actually 39 compared to non-squeakers at 43, so there was a significant difference with a p-value of 0.02. Wear has been a controversial area with pyrocarbon. My personal experience is that it's extremely rare for pyrocarbon patients to return with pain. We've had no revisions for wear. I was therefore surprised to see wear described by Caroline Cointat and Pascal Boileau in their paper in 2021. Using the Sperling classification, 52% had moderate or severe glenoid erosion on the immediate post-op film, and that was compared to 79% at 33 months follow-up. Sperling grade increased in 39% of patients, no correlation between wear and pain or functional outcome. Garrett in 2019 had 61 patients followed for 25.9 months with a pyrocarbon hemiarthroplasty. 86% had no progression of glenoid erosion. 14% had erosion evolving slightly. Another paper from 2021, 16 patients followed for 24 months. Glenoid erosion in 1 patient, 5.9%. However, there was upward migration in 2, one of whom had glenoid erosion also. Just to show you some clinical cases. This is one, he was actually the first pyrotitan surface replacement we did in New Zealand. Recalled him recently. His implant was on the 2nd of September 2011 at the age of 57. He worked 7 more years as a panel beater. In his retirement, he worked out at 4 a.m. for an hour, 5 days a week. He also practiced jiu-jitsu and worked out on a punching bag. And this was his pre-op X-ray with quite severe osteoarthritis evident. And this was his immediate post-op portable X-ray. And if you have a look at the extent of joint space narrowing, it's quite considerable through here. And then if we look at him now, 12 years down the track, his joint space looks quite reasonable on both AP and on axillary lateral views. And there was a measured 0.8 millimeters of wear. This is his function. In 1996, this 18-year-old was knocked off his motorbike at the lights, sustaining a comminuted intra-articular fracture of the scapula. He had an open reduction internal fixation with a 6-hole plate, which was later removed except for one broken screw, which acts as a poor man's RSI. He developed OA requiring pyrocarbon hemiarthroplasty. And if you look at the distance between the screw and the subchondral bone plate, 7.3 millimeters in 2018, 7.1 in 2023. So a minimal amount of wear. An interesting case who had an MRI pre-op in 2017. I just draw your attention to his glenoid, where you can see some irregularity in this region here. And then 7 years down the track with his pyrocarbon hemiarthroplasty, you can see the same signs on the glenoid. So really very minimal wear evident on these views. Very difficult to show wear on plain X-rays. You really need CT scans to do it, and it's a difficult thing to measure. Claret et al. In 2020 produced an interesting paper. They used curved pyrocarbon head on flat cortical bone, comparable to the flattened osteoarthritic glenoid. This gave rise to high local forces of 320 megapascals, which is well above the 200 megapascals compressive strength of cortical bone. This resulted in rapid penetration to a depth of 0.75 millimeters, following which the contact pressure fell to 40 megapascals, and the wear rate fell to 0.28 millimeters per million cycles, so exceptionally low compared to this cobalt chrome wore at 12.6 millimeters per million cycles, which is a 45-fold difference. Cointat and others in 2021 at final follow-up, glenoid erosion had evolved in 23 patients, 39%, either to correct posterior glenoid subluxation or to improve congruency. My personal view is that initial wear is due to high contact stresses with the curved on flat surface. Once the bedding in process has occurred, the wear rate is extremely low, but we need better pre and post-op CTs to assess wear. Mark Ross has done a large number of Pyrotitan surface replacements, and he presented his work in Rome, the International Congress of Shoulder and Elbow Surgeons, in September 2023. The fracture rate for the first cohort of surface replacements, 2010 to 2012, was 5%. Fracture rate for the second cohort with better proof testing, in other words, better testing of each implant, 1%. And the fracture rate in the third cohort, 217 to the current, where they stopped using fracture-prone sized implants, which was 3 of the 12 sizes, was 0.2%. So coming down to an acceptably low rate of fracture. That's for the surface replacement. Again, the solid pyrocarbon head has never been described to fracture. Mark Ross, in his revision of a series of 511 pyrocarbon surface replacements, fracture of the implant was responsible for 12, wound infection 1, rotator cuff tear 1, new or increased pain 2, giving rise to 16 revisions, or 3.1%. What about pyrocarbon hemiarthroplasty for trauma? I think we could be using this more. Should be using it more in younger patients. This is a lady in her late 50s who sustained quite a severe comminuted proximal humeral fracture. This was her at around 10 weeks, and you can see that all is not well. And so elected to undertake pyrocarbon hemiarthroplasty, which we cemented, reapproximated her tuberosities, and she made good progress with that, healed her tuberosities, and she had good function clinically. So what do we do with this situation? A 20-year-old with avascular necrosis from steroids. Well, we went ahead and did a pyrocarbon hemiarthroplasty. So far, he's doing fine. This is our 44-year-old engineer who had avascular necrosis. And again, we went ahead with the pyrocarbon hemiarthroplasty, and he had a good post-operative recovery. Thank you.
So I am not a surgeon. I am a conventional medical doctor practicing pain treatment for more than 30 years. And I have discovered over the years that some types of neuropathic pain, regional neuropathic pain, respond very well to regional injections with dextrose 5% or glucose 5% here in Europe, without adding local anesthetics or without adding steroids. And let's say that the results have been so amazing over the years that I felt I needed to share this as much as possible. In the old days, there were no randomized controlled trials yet, but over the last 4 or 5 years, especially in Asia, several doctors have done controlled, randomized controlled trials on the use of dextrose 5% in water. For example, you find a few on PubMed for carpal tunnel syndrome. Now, today is going to be a lecture more for doctors who have no experience with ultrasound-guided injections, but more for everyday patients we meet who have regional pain, sometimes neuropathic pain, like the patient we are going to discuss today, who can be treated in a very simple, efficient way. And I will talk about this later on. We talk about today about postherpetic neuralgia, which is pain which persists for more than a few months, 3 months or longer after restitution of the skin lesions. And often primary care providers or family physicians, but also orthopedic surgeons and neurosurgeons encounter patients, mainly immunocompromised or elderly patients, with neuropathic pain after a herpes zoster infection. And PHN is the most common long-term complication of varicella zoster reactivation. And usually the neuropathic pain presents in a unilateral dermatome pattern. And it can indeed last for several months. And it's really awful for the patient because nobody seems to be able to help them because they have allodynia, pain, which may be burning or stabbing. And painkillers may be insufficient to control or regulate the pain. This lecture is mainly based on a case presentation of a patient of mine, which was published in 2022, 2 years ago, which was described as isotonic glucose injections for postherpetic neuralgia in the elderly in Korea. And you can find this one back on the internet on PubMed. And it's about an 88-year-old patient from Belgium who had several months of treatment, oral treatment and transdermal pain treatment without any effects. And she came to see me for the first time in May the 5th in 2021 and complained about severe flank pain on the left side. And of course, like usually, they are treated with acyclovir in the acute phase. Other pathologies were ruled out in the local hospital. And when she came to see me, she said, well, even lidocaine, transdermal patches, tramadol, gabapentin, nothing really works. And she wanted a second opinion. I had treated her for other problems in the past with the same treatment modalities. And so said, can you do something for this type of pain? And here the injections were given blindly without ultrasound guidance in the pain region. And of course, in order to prevent pneumothorax, no deep injections were given. And typically for neuropathic pain, we inject subcutaneously, but very, very superficially. And in this case, we even gave intracutaneous injections, so-called wheels. I will show you a photograph later on. And these injections are quite painful during the procedure. No local anesthetics were added just also to confirm that the result is due to the dextrose 5% and not to local anesthetics or steroids with just only dextrose 5%. And here you can see a photograph from her left side, taken from the side. You can see about 15 or 20 small injections, intracutaneous injections given with the dextrose 5%. And she received these injections on 1, 2, 3, 4 occasions in 2022. And the total volume is only between 5 and sometimes 10 milliliters, depending on the case, because there's only a small amount of volume you can inject into the skin. And to my own surprise, she said that even after the first session already, she had a temporary, just a few days, improvement. Remember, no local anesthetics, no steroids. And so we continued, and with each session, the improvement lasted longer, like first 3 days and 4 days, then 6, 7 days, and so forth. And she said that after only 4 sessions, her pain had disappeared completely. And she stopped all the conventional pain medication. And at some point, she's a lady with a very big house and a big garden, and she has had some troubles with her gardener, a sort of stress moment or emotional conflict, and the pain flared up again. When she came to see me, she received another session with the same 5% glucose or dextrose injections. And as you can see here, after swiping them up, and she had no more pain. On August, a few months later, I contacted her. She's also a friend of mine. And she said, since the last 5th session, I do not have any pain anymore, and I'm not taking any medication anymore. So that's the moment when I talked about it with a dermatologist here. We published this together, and we have seen several similar patients. Of course, we don't have 100% of success, but we have a rather high percentage of success. And in order to distinguish this injection technique from other regional injection techniques, such as American prolotherapy, Austrian therapeutic local anesthesia, or French mesotherapy, which are all different and yet look a bit the same, we introduced a few years ago a new term called glucopuncture. And glucopuncture is defined as a non-steroidal injection therapy using sugar water 5%, which can be glucose in Europe and dextrose elsewhere, instead of steroid injections or other injections. And as I said before, no local anesthetics are required and steroids are never added. And we have some research done, especially, for example, by Professor Lam from Hong Kong, but also some Chinese doctors in the meantime. And in Indonesia as well, there's a lot of interest, mainly to see how can we explain that sugar water can have any effects at all. And what they found, and this is a publication of 2020, they said we have stabilization effects on neural activity. We have normalization of glucose metabolism in the cell, mainly in the mitochondria, is very important, and decrease in neurogenic inflammation. And the references of this reference you can find below. So what are the effects? We mainly have effect on the transient receptor potential vanilloid receptor number 1, block the secretion of substance P and CGRP, so the calcitonin gene-related peptides, and these are pro-nociceptive substances involved in neurogenic inflammation. So this, I think, is Chinese. The first one, Dr. Wu, has published this in Life in 2022. And there has been some research and some serious double-blind studies, and all of them are on carpal tunnel syndrome. Why carpal tunnel syndrome? Because you can do it ultrasound guided. You give one injection. It's easy to standardize. It's easy to randomize, and it's easy to double blind. You can't do that when you give multiple injections, as I did in my case that I presented just now. So this is one of 2022. This one is 2021. I think these are also a mixture of Chinese or Korean physicians or professors even, who did a retrospective in study here. You can all find them on the internet. Then this was published in Rheumatology 2021, long-term outcome after perineal injection with 5% dextrose. And we have here a very interesting study as well, where 5% dextrose was compared with steroid injections for carpal tunnel syndrome. And I think this is the most recent one. And this is, again, dextrose and steroid injections compared in a systematic review and meta-analysis. And here again, the dextrose, maybe in the beginning, steroids are usually a bit more effective because of their strong anti-inflammatory and pain-reducing effects, which you don't have in that sense, in that order, in that amount, I'm sorry, with the dextrose. But here, after 6 months, they said that might even say that the dextrose is a bit better than the steroids, and of course, without the potential side effects of steroids, like damage to soft tissues, connective tissue, and so forth, and cartilage in some cases. Here's another one from an older one. You see, they go back to 2016, but nobody seemed to know about it. I was very surprised. And this is one of epidural injections with the same dextrose 5%. This is a doctor from Hawaii who did this study, and another one in India, a Dr. Pandey from Jaipur. He also did a study on the effect of 5% dextrose in caudal epidural injection. Now, when we talk about the helical puncture, it is more designed for family physicians or sports doctors or pain physicians who have no access to ultrasound, but yet see a lot of patients with these type of complaints. And imagine this is the patient sitting in front of me and ask him, where do you have the pain? And he shows me the pain goes from the neck to the shoulder. Is this a hernia C2E? Is this a facet arthrosis in the neck? We don't know. My approach here is that I start anyway, in this case with subcutaneous, very superficial injections in the superficial fascia in the area. If there are no major pathologies, we sometimes have to exclude those first, like with MRI or ultrasound. But if there are no major pathologies, this is a test to see if it is really a superficial pain from the pain receptors in the superficial fascia. If the patient is better after 1, 2, or 3 sessions, we don't have to look further. The doctor is happy and the patient is happy. And that is why we try to share this message of glucopuncture worldwide. And it's mainly interesting for physicians who see a lot of musculoskeletal pain injuries, sports injuries, even fresh sport injuries respond very well, not only injections in the superficial fascia, but also into muscle, into ligaments, and so forth. And of course, when US guidance is available, we will use ultrasound-guided injections, and especially for perineural injections, perineural hydrodissection, and fascial hydrodissection. And when we look at the history of glucopuncture, it goes back to the late 80s, in fact. I learned in Germany TLA, which is called therapeutic local anesthesia, in the 80s when I was still a medical student. And there I learned to use procaine or lidocaine, but mainly procaine for local pain regulation. And at some point, and I will show it in one of the next slides, there was an article by Dr. Kim from Korea. This is the therapeutic local anesthesia. They do the same as I'm doing now, but with procaine. And then came the publication of the Korean doctors in 1997, who saw that for trigger point injection, which I was applying every day, the glucose of 5% was even better than local anesthetics. And that was for me like a great game changer. This is originally it was only in Korean. That's maybe why some people didn't get it. But someone translated for me or I saw the abstract in English, and then I knew that this was a confirmation of my own experience. And I started to give more and more intramuscular injections with glucose of 5% since that publication, instead of the procaine. And I saw long-term results with glucose or dextrose that I did not see with the local anesthetics. And over the years, we develop more and more blind injection techniques, and we inject into the skin subcutaneously or intercutaneously, like the patient I discussed earlier on, in the superficial fascia, in muscles and ligaments. And we still use these dextrose 5% with, let's say, a lot of enthusiasm, because it's very inexpensive. It is very available. It's a very safe product. But unfortunately, the pharmaceutical industry is not interested because it cannot be patented. And so we have to rely on universities who work independently to do these randomized controlled trials, like the ones I showed you about the epidural injections and the carpal tunnel injections. And because of this situation, glucopuncture is mainly interesting for doctors who serve in low-income countries, or for doctors in rich countries who have to deal with low-income countries, or patients, or with patients who are not covered by insurance. And that's also why I started this international project called Sweet Solution for Medics, where we give the information about the glucopuncture for free. So no, you don't have to follow very expensive or let's say international courses. You can have a free online course for beginners for free online. You can check it on the website if you would be interested. So these days we inject into joints, muscles, ligaments, around tendons, into the superficial fascia, and so forth. And we focus on injection techniques which are easy to learn and safe to apply, and can be done even outside the hospital. A busy family physician who has no financial means to invest in ultrasound, fluoroscopy, or PRP. And if you would start to do this, then we also have to sort of zoom out and, let's say, approach your patient differently. And in our case, if we don't have ultrasound or scans, additional questioning and additional examination are very important. For example, a patient coming with sciatica, he may have, according to the conventional diagnosis, CD, he may have a herniated disc, but maybe the pain is coming from a trigger point deep in the gluteus minimus muscle. That's not on the MRI. That's not on the ultrasound. A patient with pseudosciatica may suffer from these. The conventional diagnosis is, oh, you have a hernia on the same side, you need to be operated on. And sometimes these patients come to see me first because they're afraid of the operation. And then I say, I don't know for sure, but my examination will maybe confirm one of those two options, and then I will inject them. And if you get better, we know we can get you better without the operation, which is not always, of course, so successful, but it can be that way. So when the functional diagnosis is different from the conventional diagnosis, we're going to test it and see the results after one or several sessions. And if we're in doubt, of course, we will send patient for blood samples, MRI, ultrasound, and so forth. But in this case, we're literally guided by the patient's hands and by our own hands. For example, here, the patient says on the left photograph, I have pain here. It's there for weeks, months, or years. It's worse with stress or when I'm typing the computer for a full day at work. And I inject in the fascia, which is like subcutaneous, in her pain region. And if she's happy after 2-3 sessions, both the doctor and patient are happy with the results. And I know that this technique looks a bit simple and maybe low-key, even unprofessional, especially for orthopedic surgeons or specialists in big hospitals, because it's almost too simple to be true. But if you don't believe this, try it on yourself, on your partner, on your children, or on your parents, and see how they respond. You might be surprised that we have an interesting ratio between safety and efficacy. And on top of that, side effects, we still haven't found any, even not for diabetic patients or patients on a sick diet, because our dose is so low. 5%, 5 cc of 5% is negligible. So what type of injection we give? We typically give multiple injections, as you saw on the patient I just showed you in the trapezius area. In pain points, in trigger points, both muscles and ligaments, and as I said before, also intercutaneously for neuropathic pain, and intersuperficial fascia for vague pain, which means that the patient points out a larger area, like starting from the shoulder, going down to the elbow, but no pain in the neck. How can you explain that? There are so many options here. This patient says, I have pain in that side, but what is it? I mean, his X-rays of his hip were normal, X-rays of his knees were normal, so they send him to the physiotherapist for massage or whatever. But we can treat this very easily with our injections. Here, the patient points out, this is an older lady with so-called severe joint degeneration of the right knee. Her pain was gone after 5, 6, or 7 sessions, just superficially with the same product. Don't believe me here, please. Check it out for yourself. Same here. Here we gave intermuscular injections in the pain region in the left low back. Here we use a 4 centimeter needle at 27 gauge, and we inject in a sagittal plane intramuscularly in the paraspinal muscles. And a lot of the injections that we give are what we call examination guided, which usually means palpation guided. By palpating the region of the pain, we can sort of figure out how long is my needle going to be, how deep is the lesion. Here, for example, I have to push like 0.5 centimeter. This is probably superficial fascia. Here, also maybe the tendon, the patellar tendon. Here the patient shows this is my pain area, and then we're going to look for example, pain points on trigger points. Trigger points are points which refer pain to a distance. It was invented by Trevor and Simons, mainly for the muscles, but it also is applicable for muscular trigger points. And for example, here, this patient, this is so common. This is not a real patient, and on the right side, that was me 20 years ago. But you see that the patient shows he has pain in the patella area, but during the examination, I find muscular trigger points in the quadriceps muscle. And by injecting only above the knee and not in the pain region, the pain was gone. And I'm not talking about 1 or 2 patients. I'm talking about hundreds of patients. Some of them are published online, and you can find them if you type in my name. Here, for example, this is a patient. You see it now from the top. You can see his show. He has pain on the front of the knee, near the patella region, and but the ultrasound was normal, MRI was normal. I look in the quadriceps area, and I can find superficial points in the fascia or deeper points in the muscles, and inject the same product again there. So what are the goals of the glucopuncture technique? We modulate regional pain, we support tissue repair, and we regulate fascia integrity. When do we do it? How much? How frequent? And so forth. For acute lesions, like for example, a muscle tear with a football player, you can do it twice a week, and maybe they need 1, 2, or 3 sessions. For chronic lesions, you will need more sessions. This is not steroids. We are not putting the dust under the carpet. We are really going to ask the body to repair itself, and that may take several sessions. We usually start once a week, and once it's better with once a week, we go to once every 2 weeks or once a month, and need typically between 3 and 10 sessions. So patients have to be a bit more patient than with steroids, but they also don't have the potential side effects. In some cases, there is some apparent clinical worsening of the symptoms, but that means that the body is trying to repair the tissues, especially connective tissue, fascia, also muscle tissue, and that may give temporary discomfort. So it's not a bad sign. That's what I'm explaining here. We are supporting tissue repair, so there may be some worsening of the pain or swelling. And we have to explain to the patient that this is not necessarily a bad sign, but it's important that you warn yourself, your patients about this. Of course, we don't give injections in certain areas, and we stay away from specific skin lesions or especially skin tumors and so forth. But apart from that, the list of contraindications is extremely limited. Comparing the glucopuncture versus prolotherapy, because they also use dextrose or glucose, but in much higher concentrations. They also used in the old days phenol or sodium morate. There, these are what they call injections of irritants. They create osmotic cell shock, which gives that the body reacts to this tissue damage, and that will lead to proliferation of connective tissue. hence the name prolotherapy. And unfortunately, there are still a few doctors in Europe and elsewhere who use the old term prolotherapy when applying dextrose of 5%, but that will take some time. Of course, prolotherapy is more effective than glucopuncture when dealing with weak and thin ligaments, because it really makes your ligaments stronger and thicker. And there is another technique by a Australian doctor called perineural injection therapy. They also use the glucose of 5%, but close to the nerves. That's what, hence the name perineural. But glucopuncture, by the way, is more focused on refer pain, like injecting trigger points in the fascia, muscles, or ligaments. And as I said before, pain in the front of the knee can be referred from trigger points in the quadriceps muscle. This is one of those typical signs or characteristics, rather, of glucopuncture, including also that we work a lot on superficial fascia, which is not the subject of today. So I want to close down here. I have many videos which you can see on the internet. On the glucopuncture.com website, you can click on and see a list of references. You can go further to Sweet Solution for Medics, and down there, you will find a free online course for beginners where I've explained everything I'm explaining here. I'm also talking about the fascia injections in more detail, not just about neuropathic pain. And this is mainly designed for doctors. I've been teaching for the second time now in Africa the glucopuncture technique. I've been teaching it in many countries, and I hope to teach it more and more, especially in low-income countries. They can't afford an ultrasound machine in their office. They can't afford to have PRP equipment, or their patients can't pay for it, or they don't have any insurance, their patients. So for them, that's why I designed the course with easy injections, and they can access it completely free. I hope, or there might be a few questions or remarks. Please go ahead. I'm open to all remarks. And don't forget, glucopuncture is a very young therapy. It's about to develop. It's still in the development and becoming, I hope so, a major player in the field of pain management, not just neuropathic pain, but also let's say, minor musculoskeletal conditions. Even Dupuytren is one of our indications. We just inject into the palm. That's another of my publications. So please go ahead if there is any remarks or questions.
Okay, so good morning. Sorry for the delay.
Could you please turn on your video?
Yeah, just a second.
Okay. Yes,
Okay.
perfect.
Hello, good morning, everyone. Sorry for the delay. So the topic of my today's presentation is anatomical considerations and evidence-based management of partial flexor tendon injury in hand surgery. I'll be talking through about comprehensive review and diagnosis about tendon injuries, what is the current literature, management, and the rehabilitation methods. So flexor tendon injuries, the incidence is around 4 to 14 per 100,000 people. It affects primarily the working age population, as it's generally a traumatic injury, and people with active jobs and occupation get this type of injury. There is significant morbidity associated, as it's in the working age population, and there has been quite limited data available in the literature about the partial lacerations. There is good amount of literature in terms of partial tendon injury. There is a scarceness of data. Going to the literature, there is no comprehensive published studies on partial flexor injuries that we came across when we worked on this project. So in terms of anatomy, as an orthopedic surgeon, you might be aware about the anatomy of flexor tendons. So there are per digit, there are two flexor tendons per digit. Your two big muscle, that is your flexor digitorum superficialis and your flexor digitorum profundus. Through these tendons, you pass through the synovial sheath of them, and it's a complex procedure, complex setup where you have 5 annular pulleys and 3 cruciate pulleys that keeps this tendons in place through the pulley system. It enables efficient finger movement, and the most important thing function of the pulleys is to prevent bowstringing. In terms of the anatomical zones of the hand, we need to define them before going ahead with the tendon, partial tendon rupture. Zone 1, approximately it goes from your FTS to FTP insertion. Zone 2, it's one of the most important area because it is commonly called as no man's land. It zones from the proximal part of A1 pulley, and it is one of the most challenging uh, zone of tendon injury that we'll come across. Zone 3 is distal edge of flexor retinaculum. You can review the diagram as well. And zone 4 is within the carpal tunnel. Zone 5 is proximal to the carpal tunnel. So what does a tendon compose of? What's the biology? Structurally, tendon composed of type 1 collagen. It accounts for around 95% of the tendon structures. There is a structure wherein it has endotendon, then fascia, epitendon, and peritoneum. Nutrition sources. What nourishes your flexor tendon is your synovial fluid, vincular circulation, and peritoneum. So what's the diagnostic challenges in terms of tendon injury? Firstly, visual estimation. Partial tendon injury, there is MRI and ultrasound available, but most of them is based on surgeon's visual estimation, and there is around a 11% error when you eyeball it and consider it's a partial or full thickness tear. Most error around 80-60% of the laceration mark because you cannot visualize with the naked eyes all the partial fracture tear. In terms of the measuring techniques, there are, as you can, firstly is a naked eye. Second, normally surgeons use a ruler or a marker caliper, and there are some diagnostics tools as well in order to measure them. So what is the current treatment option? So in terms of partial tear, first thing is non-operative management. Second option is the surgical repair, and third is to trim the edges. And the most important criteria when we think of management in partial tear is how deep is the laceration, then what is the area that is affected, that is partial percentage of the cross-sectional area. Third is your anatomical location, and fourth is your surgeon's preference. When do we repair them? So the surgical consideration is most studies recommend that if it is 60 to 70% laceration, then you should repair it. Some also suggest that you can actually go as high up to 90% before you need to repair such tendons. The main issues with the main complications, or I would say the main risk associated with partial tear is firstly, they cause adhesion formation, they cause tendon bowstringing, they can lead to pulley failure because you will be around those regions, and they can also lead to extensor tendon tearing. What are the surgical techniques? So there are various methods that are described. I have mentioned about a diagram of simple running suture repair. The first is modified Kessler technique. It's one of the most popular. The other methods are modified Savage or Lee technique. And in terms of suture material, we can either go with monofilament suture or minimal cladding resistance, as any polyfilament suture will cause abrasions over the surface and lead to infection as well. The goal is you should have minimum friction and you should prevent adhesions in operative management of this tear. What is another method that is trimming technique? So if it's a partial tear and you decide not to go forward with the suturing, what are the advantages of trimming technique is? Firstly, you reduce the risk of triggering or tendon entrapment because you won't be going through the whole depth of the tendon. The techniques such as resect sharp edges that promote healing. Other is create beveled edges, and the third is inside out technique. This technique is effective for your problematic laceration specifically. So in terms of rehabilitation principles, what are the goals when we deal with partial tendon flexor injury? First is your restore function and tendon cladding. Whenever we fix such tendons, the first thing we check is if the tendon is cladding or not. If it is not, then it will cause bone stringing and cause tendon entrapment as well post-op. Second is avoid a tendon rupture. That will be a big issue if you accidentally convert a partial tear into a full tear. Third is shift from immobilization to early mobilization. And fourth is challenges in the protocol development. So the rehabilitation methods that are commonly discussed are firstly immobilization. You can put a simmer splint or you can immobilize the finger after you have repaired it or use as a trimmer technique. Second is you can allow for passive motion exercises, or you can slowly discuss the patient with the hand therapy and allow for place and hold exercises that will gradually increase the strength of your repair. Otherwise, you can also think about active motion exercises regimes. The issue with rehabilitation in partial tendon injuries are that there is no consensus on optimal protocol. It's generally surgeons' preference about their own experience, that is level 4, as against a systematic review or meta-analysis about what is the best way going forward. And that is the reason that one of the recommendations of this project was to promote for a randomized control trial in terms of partial flexor tendon repair. The things which we came across as limitations in this topic was firstly, as we couldn't see much of the literature on partial flexor tendon injury. There was a good amount of literature on complete tear, but not on partial tear. As I mentioned before, there are level 4, level 5 evidences, which are case series or surgeons' expertise, but there is lack of level 1, level 2 evidence on this specific topic. There is no definitive rehabilitation protocol available that is accepted by a wider surgical community. And there is an array of surgical techniques. There is no specific one or another. There are no specific two methods that we can offer to the patients if we come across this pathology. And hence, there is a need for comprehensive research, especially in partial flexor tendon injury. So, key takeaways from this presentation, I would say, if it is a 60 to 70% laceration, consider surgical repair. You can go for a trimming technique as well. If not, if you decide for a surgical repair, then prefer a simple running suture. You can use a monofilament for that. Use a core suture for strength, and make sure that you have a dedicated hand therapy team or a dedicated post-op rehabilitation protocol put in place when you are managing this injury. Every patient is special and every patient is different. So make sure that your rehabilitation regime is not a blanket regime, but based on the patient's specific approach. And most important thing is make sure you allow for minimum tendon cladding resistance. Otherwise, your physiotherapy and your rehabilitation protocol will suffer significantly. So conclusion, consider partial flexor tendon as a complex injury. It will need array of teams, including your radiologist for scans, your physiotherapist maybe dedicated hand therapy team, and colleagues which have dealt or are dealing with partial tendon ruptures. Is a multifaceted management system, and there is definitely a big need for advanced research based on them. And the important aspect about partial tendon is anatomical understanding, what is the biomechanical consideration, and how we can cater to patient-specific strategies on that. These are the references if you want to go through, but yeah, thank you.
This is a literature review about pelvic radiotherapy induced pelvic insufficiency fracture. So the aim of this study, can you please go to the next slide, please? So the aim of this study, it's a literature review, so the aim of this study is to investigate more the effects of the radiotherapy on the pelvic bones, and explore the options of protection of the bone, and the preventive strategies. So the methodology was basically, next slide, please. Next slide, please. Can you hear me? Hello?
Yes, doctor.
Hello?
Yes, doctor.
Can you please turn to go to the next slide?
Okay.
The methods was we basically looked up the previous research that was done on that topic, the radiotherapy, and we searched on Google Scholar, Science Direct, PubMed papers. All kind of papers were included in that topic, primary research and secondary research, except Vox. But otherwise, every other single paper was included in that study. We filtered the irrelevant papers, and we filtered the duplicates, and we came up eventually with 47 articles, and we summarized them, and we flagged up the key findings and the recommendations for future research on that topic. Next slide, please. So the findings were as follows. We found that all patients who have undergone radiotherapy on the pelvic bones for basically, we know that there are different reasons people go for radiotherapy on the pelvic bones: gynecological malignancies, GIT malignancies, prostate cancer, and stuff like that. So all the patients who've undergone a pelvic radiotherapy sustained like 97% of these patients. For example, this is a pie chart, but shows that 2.1%. There was 2.1% fracture risk in patients who have received irradiation. A total dose of this is actually was investigating more the dose of the radiation. It's not just radiotherapy. So we were looking at the dose. So all the patients who have undergone radiotherapy of less than 50.4 GY, which is the unit of measuring the radiation dose, sustained 2.1% of them were fractures, and 97% were sustained no fracture. But if you please go to the next slide, we will find the other way around in the other. So all the patients who have undergone radiotherapy overdose more than 50.4 GY, more than or equal 50.4 GY, actually 21.7% of them sustained fractures in somewhere in the pelvis, and 78.3 have no fractures. So basically, it jumped from 2.1 to 21.7 by just increasing the dose of the radiation from below 50.4 to above 50.4. So it's a big jump actually, and the dose matters, not just the radiation therapy on its own, but the dose plays an important role in leading to the insufficiency fractures that we can see. Next slide, please. Oh yeah, so this is basically like a nice diagram illustrating the common sites of pelvic fractures that can be sustained as a result of the radiation therapy that the patients might have undergone. It can actually include the proximal femur and the hip as well. It's not shown here, but it's mainly around the pelvis because we were studying the effect of the radiotherapy on the pelvic radiation for patients who might need to go through radiotherapy for some reason, for some malignancies in this specific region of the body. So the most common part that can be broken in the pelvis is the sacral ala, the medial portion of the ilium, followed by the upper sacrum, followed by the lower sacrum, and then the pubis comes last. As shown on this diagram, it's a very simple one that just basically was drawn by one of our authors, and it was really illustrative and just can sums up all the common sites of pelvic fractures as a result of the radiation therapy. And by the way, it is I just want to stress on the fact it's called insufficiency fractures because it is radiation induced and it affects the bone health, minerality, and vascularity. And this is what I'm gonna come to. Next slide, please. Yeah, so this is actually one slide with summing up all the research, all the paper that was published. I'm curious if you want to look into more details, you can go to the paper. So it's basically what we investigated the pathophysiology or the pathogenesis, which is effect of the radiation on the bone, and we find that there are different hypotheses. But what the most common hypothesis that people agreed on with that the radiotherapy affects the bone minerality. It damages the osteoblasts, osteoclasts, weakens the bone health, and diminishes the bone matrix. This is in a way affects the bone health and leads to the bone insufficiency fracture. But it can also affect the bones by damaging the blood vessels, causing what is called obstructive vasculitis, to be more specific, endarthritis and periarthritis. This will basically cut off the blood supply, goes to the bone, and leading to the necrosis and gangrene of the bone, and eventually, by any subtle impact, a fracture can happen. So it just weakens the bone by different reasons, affecting the bone matrix and causing occlusive vasculitis. There are different investigations and diagnosis. So most of the patients with insufficiency fractures should be symptomatic, but it's quite vague symptom. It's very non-specific, can be misinterpreted easily. Patient can present with just lower back pain, and lots of other problems can lead to the same symptoms. So it can't be relied on can be relied on clinically. But we need to actually, that's why we want to flag up here in this research. You are any patients with a history of irradiation to the pelvis, you need to think of insufficiency fracture whenever they have lower back pain or any vague pain around the lower spine or the pelvic region or even proximal femur as well, but which is uncommon. But small proportion of the patients can be asymptomatic, and that's when you need to just when you take thorough history from the patients, once you know that these patients was exposed to radiation therapy to the pelvis before, you need to think of pelvic insufficiency, even if the patient is asymptomatic, and you need to start thinking of doing some investigations, starting with plain radiograph. But to be honest with you, it can't be missed because many of these fractures can be very subtle and can be missed on the plain radiographs. CT, good sensitive. Has got a good sensitivity to delineate the fracture lines, and finding and actually like capturing the fracture, but it can't be misinterpreted with metastasis as well, because most of these patients have had probably will have history of cancer with mets or stuff like that, and that's why they have undergone radiotherapy. So when you CTA, it can distinguish at some point or with some sensitivity between the radiotherapy-induced insufficiency fracture and metastasis-induced insufficiency fracture, but it's not the best to capture that kind or to distinguish the two kinds of fracture. It has got a sensitivity of 60 to 75%. Another very good imaging modality is a technetium scan, TC99M. This scan can show what is called a typical H-shaped pattern, specifically in the bilateral sacroiliac joint fracture with sacrum as well. So if you can, on the pelvis, it will be an H-shaped pattern. It is very good, but there is a downside of it. There is also like there is a problem with it, but that it can't be absent, unfortunately, in some cases. But if it showed up that H-shaped pattern, this is most probably that radiotherapy insufficiency fractures. But what we came up with eventually that the MRI is the best. Like it hasn't got this. It had got sensitivity of 100%, almost 100%. So way better than the CT, and better than the technetium scan. That the fact that it can't, it's always it will always tell you what's on there. Because in the technetium scan it can't be missed, or the H-shaped pattern is not always there, and it can't be. It's not always like the H-shaped kind of fractures. Sacroiliac joints with pubis can be anywhere else, as shown in the previous diagram. So the MRI is the most sensitive, 100%. Can delineate the fracture lines. Can distinguish, which is a very important thing, that it can distinguish radiotherapy-induced from metastasis-induced insufficiency fractures. That's our recommendation in terms of how to diagnose it. But now we come to the preventive strategies, how to try to protect these patients undergoing radiotherapy for kind of cancer around the pelvic region from having such a complication. There are some methods, and it's the people dealing with like the bone oncology, the oncological teams are better to know about these. Best to know about these things. But there's something called IMRT, in intensity modulated radiotherapy and brachytherapy. These modalities have shown that they can just target the inflected organ. The organ with tumor without affecting the surrounding soft tissues or bones, can spare the bones and just target the inflected organs by being so specific and so targeting toward the tumor. Also, you need to do some radiotherapy investigations, assess the bone health of that patient, doing some blood tests like bone profile, calcium, vitamin, stuff like that. Also, this will help have a picture about how brittle or how good the bone health of that patient you're going to do radiotherapy for. So you can actually predict the outcome, and you can start as soon as possible, take all the precautions needed, and decide whether or not you can weigh the pros and cons of doing the radiotherapy for that patient. Depending on the pre-op assessment. Also, you can do DEXA scan, just check the bone health before you attempt to do the radiotherapy. Unfortunately, the known bone protection pharmacological interventions from our medicine, drugs like bisphosphonates and stuff like that, haven't shown any promises in terms of bone protection for the patients undergoing radiotherapy. It can protect the bone, obviously, but from some other, like osteoporosis, not radiotherapy. But there are two other medications that shown promises in terms of bone protection for the patients undergoing radiotherapy, like amifostine, sorry if I'm not pronouncing right, amifostine and bisphenoxamine. These are two medications, kind of discoveries. This is maybe the most important message. These two medications have shown very good results in protecting the bones of patients undergoing radiotherapy, like, for example, amifostine protect the vascularity. Amifostine can protect the bone health and minerality, and bisphenoxamine protect the vascularity of the bones. And so eventually, which basically those two medications, if you can remember early when I discussed the pathophysiology, bone health, affecting the bone matrix and affecting the blood vessels, it was found that those two medications play a crucial role in preventing those two pathogenesis, two pathophysiologies that happen, that's taking place in the process of affecting the bone health. So they are interrupting the bone affection through the bone. They protect the bone matrix. One of them is amifostine protect the bone matrix, and this bisphenoxamine protect the blood vessels, the vascularity of the bone. So it disrupts that pathogenesis cycle from happening. So protect the bone health and decreases the risk of bone insufficiency fractures in patients. Let's be specific, in the patients undergoing radiotherapy, because there are lots of other insufficiency fractures can be caused by other problems. But here I'm talking about the radiotherapy induced insufficiency fractures. Yeah. So yeah, that's it. Thank you so much. And this is an MRI scan, by the way. We looked up the scans in the radiology departments of the trust I was working at back in the day when I was doing that literature. And we found this MRI scan of one of the patients. It was a database in Bolton NHS Trust. And kindly, the consultant that helped me find this scan, and it's annotated scan showing where exactly the insufficiency fracture. And looking at the history of that patient, and the report, it says that the patient has undergone radiotherapy for rectal cancer, and within like a couple of can't remember exactly the duration afterwards, but very recently, very soon after having radiotherapy, the patient sustained that insufficiency fracture shown in this MRI scan on that slide. That's it. Thank you so much. Happy to receive any questions.
So, good morning. Topic I'm presenting is a very interesting quality improvement project. The name is Operation Notes. And what we did was we did a small quality improvement project which depicted how we identified a problem, how we introduced a change. And as an outcome, we tried to improve the compliance of a local DG8 hospital for the guidelines as mentioned by the Royal College of Surgeons, England. So it was based in King's College Hospital in the Princess Royal University Hospital site. So the aim of this project was the RCS has produced guidelines regarding what all things should be mentioned in the op notes, and there is a specific inclusion for the things that needs to be mentioned while writing operation note for any surgical procedure. In this study, we focused on the trauma and orthopedic operation notes, and hence we did few changes to the official guidelines when we introduced and when we started our data collection in the first cycle. We checked for the adherence of our local setting to the RCS guidelines when the operation notes were being written. So the RCS mentions that all 100% of the operation notes should definitely include this parameters. We have added one or two aspects and we have removed one or two so that it inclines more with orthopedic surgery rather than a blanket surgery. So date and time, whenever we write a op note after the case, they should mention the date and time, whether it was an elective or emergency procedure. It can be in emergency, it can be a CPOD case as well. We have to mention that. Making sure we name in block letters if it's a paper-based system, or if it's online, then we can directly put in the surgeon's name and assistant, and also the grade of the surgeon and assistant. Name of the theater anesthetist and the grade of it, which we mentioned, although that is optional. Operative procedure that is carried out with specific side, if it's a right or left sided, and what was the incision length, what was the incision. If not length, we have to mention where the incision was and what were the landmarks for it. Then when we did the approach and when we found out our pathology, then what was the operative diagnosis and the operative findings, and followed by a signature at the end. In terms of orthopedic, we did add few aspects, such as if there was any prosthesis used. If so, what was the prosthesis used? Online, we can add to their barcodes and their details, and because we have a theater register as well. If we are doing an on pen and paper, then we should mention about the company and the implant that we have used. Then, while coming out of the wound, what are the closure techniques we employed, and was there any antibiotic prophylaxis that we went through? Also, in terms of orthopedic, specifically in lower limb as well as upper limb, we should also describe in detail about the DVT prophylaxis, if it is applicable. If it is not, just we have to mention that no VT prophylaxis is applicable. And last but not the least, the post-op instructions detailed. And in terms of the new BOSH guidelines, I haven't mentioned that we have to also include the weight-bearing status clearly in the operation notes. So we did 2 cycles. It was a retrospective study. We did 2 cohorts of the data collection. We had a good sample of 30 patients have underwent operation. First was in the May to June, and the second cycle was in from October, for the 2 weeks of October. We got around 30 patients. We assessed their operation records and compared to the RCS guidelines, as it was a part of our service evaluation. So there was no involvement of the ethics committee or the involvement of consent from the patient. And in order to make it more precise to our topic, we did remove few of the aspects from the guidelines when we were assessing them, such as was there any problems or complications, any extra procedure was performed, and the reason why, any tissues was removed, added or altered. In that case, we mentioned about the implant that was added and anticipated blood loss. So what we recommended through this study was this intervention. So I will describe in detail about the first and second cycle results. But the change which we introduced was that we were doing an online system for electronic patient record, and we introduced a simple acronym, as in all the points were mentioned with a blank in front of them, which can be filled as a fill in the blank. And we did add this to the online system on the EPR, that people can use it as a template while writing them. And in that small change which we try to introduce, and then we assess the change in your first and second cycle, which we can see. Okay, so the results of the first cycle and the second cycle, as we went through, we realized that the name of operation, the date and time, and the signature, there was 100% compliance in both of the cycles, which we expected. But the main results which were remarkable were in the first cycle, the name of anesthetist, only in 70% they had been mentioned. But when we introduced the acronym and we discussed about it in the meetings, and there were posters about the acronym, the compliance with that increased to a significant 100%. Same as operative findings, it increased from 70 to 100. And antibiotic prophylaxis, where it was required, it was mentioned initially as 70% in the cycle, and it increased to a significant 100%. In terms of DVT prophylaxis, specifically for patients who were non-weight bearing or partial weight bearing, this parameter change, it was quite low initially before we introduced our change, That was 53%, which rose to a significant 93% in the second cycle. Still, there is a scope of improvement, as you can see. And in terms of incision, it was merely 60%. Patient going for a surgery, there was only 60% of people who did mention about the incision site and incision length, which increased to 93% after introduction of acronym. The parameter which were significantly low as were the ASA grade. As in the team brief before the case, we do discuss about the team briefing and ASA grade as well. Only 43% of the people mentioned that in the op notes. Can you imagine the ASA grade will have not exactly directly proportional, but will have a proportionality to patient outcome post-op as well. But this was not mentioned in the op notes, which increased to 96% when we had introduced the change, and only 37% of the surgeons had mentioned about was it elective or emergency procedure in the operation notes when they were being written. This increased to a significant 70% when we introduced this change. As you can see, there is still a significant scope of improvement, as with more ward-based teaching, more teachings in the trauma meetings, and as well as poster and awareness campaign that needs to be circulated regarding this. In the parameters which we were doing not too bad, I would say. They mentioned about detailed post-op instructions. Cycle 1 was 97%, which increased to 100%, as well as name of operating surgeon assistant. You can imagine 7% of the cases, there was no mention of who did the operation, who was the assistant, which definitely improved to 100% after introduction of the acronym. 17% of the patients, there were in 17% of the patients, there were no mention about the closure technique, which significantly rose to 93.3%, and 77% of the surgeons didn't mention about what they found in TROP, that is operative diagnosis, as well as if they used any processes or not, which rose to 100% on operative diagnosis, and which only rose marginally to 80% in the cycle 2 of processes. So as coming back to that, it was a simple change which we introduced was to create a small acronym. We also did additional things such as discussion about this acronym in the trauma meetings. We had some posters that was printed and sticked into various aspects where the operating surgeon or registrar will go through that before writing the notes. And this was discussed, and there was a significant change because of the small intervention we did. The conclusions of this study were adherence to operation note guidelines was increased significantly because of the introduction of the acronym. Although there is still a big scope of improvement in terms of mentioning if it's elective or emergency surgery. As a department of any surgical department, we should always strive for 100% in all domains. That is not only important for adherence to the guidelines, as well as post-operatively there is less confusion in that. The introduced pro forma, we called it as #operation in the acronym expansion, did allow the department to meet the standard, and this improved the patient care and significantly improved the communication between the teams. So what do we recommend was to spread this acronym and the use of it by word of mouth among registrars and consultants or SHOs who are involved in writing the operation notes. We plan to again re-audit to see how we have improved in the last couple of 1 or 2 years, and was there any further scope of improvement that was possible, and was there any wider application among the surgical specialties in terms of can we spread this into ENT of ophthalm or general surgery as well in terms of cross-fertilization of this acronym in different specialties.
my topic is robotics in arthroplasty and its historical progression and contemporary application with artificial intelligence. First of all, I'm like an electrical engineer. I'm not a doctor, and I do work with orthopedic surgeons. And our company, Smith and Nephew, it makes the surgical devices, the robots for knee replacement and hip replacements. And okay, so the work I'm gonna present it's mostly based around the research paper which I published in Curious, which is part of like Springer Nature, and the details are on the screen. Okay, let me start my presentation. So I'll start by introducing what is the history of robotics and how it got applied into joint replacement surgeries. So the word robot came from the Czech novel Rossum's Universal Robots. It was written post First World War, written in 1921, and so the author Karel Capek, he invented the term robot, and that's being universally used nowadays. In the play, the main character Helena is a robot sympathetic, and Radius is that robot you can see on your top right of the screen. So that's the brief modern history of robotics. Now about like how robots entered into surgery and the field of orthopedics. So excuse me. First of all, the first robot was patented by George Devil in 1954, and then he teamed with another entrepreneur, Joseph Engelberger, who is most people call him the father of robotics, and together they formed a company named Unimation in Connecticut in 1961, and they supplied robots for General Motors to extract hot metallic parts from a casting machine. So that gave rise to first modern robot, and its first application of that robot in the surgical field was the Puma 560, which was used to take neurological biopsies in 1988, and the scope of the Puma 560 was extended to transurethral resection. So instead of biopsy, it was used to do like remove the occlusion on the prostate. And in the same time, there was Dr. William Barger, who partnered with IBM, one of the software giant at the time, and with that funding, they started developing a robot that could do like hip replacement and knee replacement. And Robodoc was the first robot that was used for orthopedic surgery. And after that, another robot by the name Casper, it became popular. So Casper was like a semi-autonomous robot. I will distinguish between these robots in the next slides. And these are like mid 90s, mid 2000. But like recently, like in 2008, MIPO from Stryker, their robotic arm cleared the FDA, got the FDA clearance, and that that paved the path for like modern robotics in orthopedics, like TKA and THA applications. And like these this MIPO robotic arm used the preoperative CT images for the TKA and THA applications. Now, like few example of like modern image guided surgery system. One of them is like the Navio surgical system, which is manufactured by Smith and Nephew, the company I work for. I personally worked in designing these two robots, and our second generation robot is called the Cori surgical robot. And I'm working on the third generation of surgical robot, which could do like multiple applications, like shoulder and others. So these are like few examples of the modern robotic systems. Now, to understand the robotics, surgical robotics for orthopedics, so they are classified into three main, based on like whether they are active, semi-active, or passive. So the passive robots, they don't do much. They just offer more insights to the surgeon, and like slowly this technology is in decline. And Brain Lab is one example of such an application. Another type of robot are the semi-active one, which rely on the haptic feedback. The one I showed you, like in the previous slide, the Cori surgical robot is a semi-active one. So it gives the surgeon feedback. The surgeon is in control while removing the bone from the hip or knee area, and there's active participation from the surgeon. But the full, and on the other hand, there are robots which are like fully automated, they are classified as active. For example, the MIPO robotic arm from Stryker. So that's pretty much like plug and play. The the intervention required from surgeon is very minimal. So based on like doctors, the surgeon's comfort level, the surgeons, they choose the technology. And there is not like much difference in like surgical outcomes with this active or semi-active. Studies have shown that they pretty much achieve similar precision. Now the next classification are the image-based robots, and imageless robotic solution. The image-based solution, they use some form of CT scan, MRI, or another radiological procedure, and these are like taken pre-operative before the joint replacement surgery, and the whole surgical plan is is based on these images. And for example, the implant size, and how much, what's the deformity level, how it's going to be corrected, and the boundaries for bone removal are all determined pre-operative in this kind of system. And example of this is in image-based system is the Mako robotic arm. And a disadvantage of this system is like there's a radiation that that is given to the patient. And the second type of system is the imageless robotic solution, and they rely on the anatomical markers that are placed on the body during the surgery. And that's how like all the implant size, alignment, and what area of bone needs to be cut, and the whole implant bone preparation for the implant is done. All that calculation is done intraoperatively, which is like very different than an image-based system. And advantage of imageless robotic solution are like lower operating cost and no radiations to the patient. So, and in in US, for example, so some of the insurance they charge more for a CT scan or an X-ray, so it saves cost to the patient. Next type of the robot are the one that are based on the implant choice, whether the implant use proprietary implant or surgeons can choose their implant. There are very few robots that are that can offer surgeon's choice. One was like RoboDoc. I think Surgical they purchased it. So very few robots allow the surgeons to choose the implant. Mostly it's like, but if it is like Stryker, Mako, whatever companies they is making the robot, they test with with that implant and they recommend using that company's implant. So they that kind of like forces the surgeon to use that company's implant. Another another technology that is discussed is the navigation, which is a passive technology, and it doesn't improve uh, like doesn't add to the surgery as such, but it gives more insights to the surgeon, like the surgical area and and the navigation is of three type. Either it's like imageless, which uses like some passive markers, or fluoro navigation, which is X-ray or a CT scan based. And CT scan based navigation is the most accurate. Some example of navigation technology are Orthopilot, Brain Lab, uh, and the Striker navigation. So these are a few examples of the navigation, which is like a passive technology. Now, now I'll go on the challenges for the contemporary robots for joint replacement surgery. So the data has shown that the implant survival rate with the traditional TKA and with the RoboDoc, there is no significant difference. So the robot is at par with the traditional surgery. Despite of that, there are like multiple challenge. The first challenge is the surgeon education and the cost related to robotics, the like buying the robot. So these robots they cost close to like 1 billion US dollar or 700 million US dollar. Like that's the typical cost, and that cost ultimately gets transferred to the patient. So those are like some of the shortcomings. And then there is a learning curve with the robot. Like for example, first 3 or 4 joint replacement surgery, it might take like 50 minutes to prepare the bone, but after that the bone preparation is like done like 25 minutes or something like that. So there's definitely a learning curve with the robot. And another drawback is for example, the surgeon prefers an X implant, but that doesn't work with the robot that's there in the hospital. So that's another drawback. And another issue is the like sometimes there's some technical glitches, and the surgeon needs to switch to conventional TKA or THA. But like most of these complications are newer generation robots. So like these days, like for example, our marketing team tells us that earlier like 1 in 10 surgery was done using robotics, like for our implants, but these days it's like every third surgery is done using a robot. So robots are making a headway, and as you can see, I mean, most of the companies that make the implant, they are making their own robots also. So that seems to be the industry trend these days. Excuse me. Now, the role of the artificial intelligence in robotic assisted surgeries. So AI is a recent advancement, and that is already revolutionizing the robotic assisted surgeries. The first thing is the osteoarthritis detection. So some of the researchers, for example, Zhu et al., they showed that their sensitivity and specificity was very comparable to a experienced radiologist. Similarly, Tupin and others, they use computational neural network to grade different level of osteoarthritis, like how severe is the arthritis, and some of them has been using the the CNN models to highlight the radiological characteristics. So overall, it is revolutionizing the field of robotics and joint replacement. I mean, all these research show that osteoarthritis detection using AI is very comparable to humans, to an experienced radiologist. Next role of AI in robot assisted surgery is the implant selection. So, for example, the researcher named Boraji, they use a deep CNN to recognize the mechanical loosening of the hip joints, and in comparison to an experienced orthopedic surgeon, their model attained a sensitivity of 94% and specificity of 96%. And this helped them create saliency map to highlight the critical reason that model utilizes to diagnose. So, and which boosted the trust in the findings of the study. And Yi et al., they also address this problem by using a different type of CNN on the knee X-rays. So as you can see, they're like AI is getting better at like implant selection. It tells like what implant to use, and the chances of error are reducing. Another role of robotic assisted surgery is the clinical outcome predictions, like what's the success rate of the surgeries. For example, Ram Kumar and others, they 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 use computational neural networks, and they use that to highlight like what is the reimbursement issues and what are the outcomes. And they use like different factors like age, ethnicity, and gender and other comorbidities, and they use the Bayesian technique to accurately predict the duration of the stay and cost of knee and hip orthoplasty. And in contrast to comprehensive care for joint replacement, their proposed tier-specific reimbursement was intended to give a more equitable consideration for patient complexity. And using a lasso model, Harris and others, they studied clinical outcomes, and they were able to predict 30-day mortality and cardiac issues after joint replacement with a moderate degree of accuracy. In this Fontana et al., they also received similar results. Next, next role of AI is improving the surgical workflow. So as I mentioned earlier, there's a challenge in like learning curve when the initially when the robot is bought. So the more the patient is on the table, the more blood is lost. So that's why like AI is being used to for like surgical training and to reduce the learning curve, and use of patient specific implants are also being more common. So AI is used to like design patient specific implants. For example, Lamberts and others, they presented a unique use of machine learning in patient-specific joint replacement, and they showed that they got better results as compared to the conventional techniques. And because of this, they had to make fewer manual corrections, and which helped them streamline their workflow and cut down the time. Next role of AI in in the field of robot assisted surgery is the implant design. For example, Izensky and others, they optimized the joint model using an artificial neural networks, and they use different assumption, different models to simulate to train the data for like different variation of the loading conditions. And the neural network, it estimated the contact forces and the torques that are applied on the knee joint with increased accuracy and a higher computational time rather than like a traditional simulation model. So this breakthrough eliminates this obstacle to the routine application of the implant improvement. So now the surgeons, they can make patient specific implants. Another application of AI in robot assisted surgery is the post-operative complication prediction. The researcher McGirt and every like others, they have used AI for like lumbar surgery, like to predict the outcome, and their accuracy was 72 to 84%. And the parameters that they considered were like age, BMI, and specific pain conditions. Like most of the research on this is like on the lumbar spine fusion, not specifically joint replacement, but believe that there will be more research on this to predict the surgical outcome and the what are the surgical complication after a joint replacement. Now, in conclusion, so although initially it might require longer operative periods, but robots have come so far, and the initial cost that is associated with buying a robot, the benefits outweigh the cost and the initial pains that are associated with the learning curves. However, more research is required to clearly demonstrate the cost and efficiency of the robotic surgery for joint replacement. And there's a lot of progress that has been made in joint replacement with the integration of AI. And soon this all like as more more AI is being used, and there are more research ongoing on this issue. I believe there will be more and more role of AI in robotic surgery. So that's it. Thank you, everyone. Any questions?
Para Latinoamérica y Tailandia y el mundo, queridos amigos. En esta oportunidad voy a exponer sobre la técnica de MIPO, with helical plate in humeral fracture. Esta técnica tiene antecedentes históricos ya hace aproximadamente 2 décadas, en la cual existe evidencia sostenible que este método ayuda respetando estructuras nobles para el manejo de fracturas complejas, en este caso fractura de húmero. Aquí presento algún artículo publicado en la revista cubana de Ortopedia y Traumatología, donde se evidencia el beneficio sustantivo de este método en el manejo de fracturas complejas del húmero deficiente. También tengo una presentación, una ponencia en acta científica, Medical Science. En base a ello, tenemos que mencionar que esta patología, las fracturas diaficiarias multifragmentarias con extensión proximal son infrecuentes. De manera que manejarlos constituye un reto, un desafío, y ello implica tomar en consideración una evaluación clínica de las partes blandas, el lado neurovascular y la evaluación radiográfica. De manera que la planificación preoperatoria es vital para establecer un pronóstico en la recuperación. Es importante respetar los nervios circunflejos en la región proximal y el nervio radial, dado el recorrido peculiar que tiene en nuestro organismo, ya que estos pueden sufrir lesión primaria tanto en la lesión inicial como por la cirugía, y es necesario manejar scores funcionales, tanto de manera prequirúrgica como postquirúrgica en el seguimiento. Entonces, el estudio radiográfico nos va a permitir valorar la consolidación ósea y obtener la evaluación final de nuestro resultado. El manejo debe ser individualizado. Necesitamos un abordaje quirúrgico, un implante correcto, idóneo y sobre todo cuidar el nervio radial. La técnica de MIPO con placa filohelicoidal larga, que significa torcer la placa y ajustarla a la silueta anatómica del húmero, nos permite abordar de una manera metódica y respetuosa estas lesiones, con incisión anterolateral proximal y anterior distal. El respeto a las partes blandas, los grupos musculares, una disección cuidadosa, meticulosa, sobre todo en la parte proximal para evitar el nervio circunflejo. Entonces, respetando estos indicadores, vamos a obtener una consolidación de la fractura y una reinserción laboral óptima de nuestro paciente. El progreso o la evolución lo vamos a validar con escalas de funcionalidad y radiográficas internacionalmente validadas, tales como el score del Quick Dash y la escala de Montoya. Tenemos que la técnica de MIPO con placa filohelicoidal es un tratamiento actual en las fracturas humerales diaficiarias multifragmentarias con extensión proximal, que nos garantiza eficacia y seguridad. ¿Por qué? Porque preserva el hematoma de la fractura, reduce la lesión iatrogénica de los nervios axilar y radial. Así, mejora la curación ósea, nos da un adecuado resultado funcional y cosmético, cuya meta o objetivo es crear un mejor escenario para la curación y no una estabilidad absoluta y rígida que genera un alto costo biológico. Veamos el presente caso presentado en la revista cubana de Ortopedia y Traumatología. Se trata de un paciente varón de 28 años, obrero, que sufre un accidente de tránsito hace 28 meses, con un traumatismo aislado del brazo izquierdo, considerando una fractura cerrada humeral diaficiaria multifragmentaria con extensión proximal. La función neurovascular estaba intacta y las partes blandas presentaron una lesión T-Sharp C2. Esta es la imagen tomográfica donde se observa una fractura de húmero proximal con extensión metáfiso-diaficiaria compleja, minuta, inestable del paciente, donde procedemos a operar al paciente bajo anestesia general, en posición de silla de playa, miembro superior extendido, reducido y supinado. Hicimos dos incisiones, una de 5 centímetros, proximal y distal al foco de fractura. Vale decir, un abordaje anterolateral directo transdeltoideo proximal y un parabicipital externo transbraquial anterior distal, por encima del cubo. Entonces tenemos las imágenes de la incisión proximal, anterolateral, y la distal anterior, cuyo objetivo es hacer una técnica mínimamente invasiva que sea idónea respetando las estructuras nobles, vale decir nervio circunflejo proximal, nervio cutáneo antebraquial externo, lateral, adistal y sobre todo que sea paralelo al nervio radial y evitar esta iatrogenia importante. Entonces, en la parte distal, en el codo, aislamos el nervio cutáneo antebraquial. En este método empleamos las grifas o moldeadores, una placa filos larga y que le vamos a torcer a 90 grados de forma helicoidal y la vamos a insertar de proximal a distal, vale decir, de la incisión anterolateral proximal a la distal, que es anteromedial. De manera que vamos a encontrar este detalle donde la placa está por encima del hueso y debajo de las estructuras blandas, respetando el nervio axilar proximal y el nervio cutáneo antebraquial lateral a distal. Durante el seguimiento de la evolución, en el postoperatorio inmediato encontramos esta silueta donde obviamente existe un proceso de recuperación leve, poco a poco, paso a paso, y hasta que se va instaurando una mayor consolidación de la estructura y donde tras transcurridos 24 meses, 2 años del evento, el paciente obtiene un buen resultado funcional y cosmético. Véanse los movimientos de abducción, rotación externa, abducción, rotación interna, y con un adecuado resultado cosmético aceptable para el paciente. Ya estas son radiografías actuales, donde evidenciamos la consolidación ósea definitiva de la fractura compleja en las vistas frontal, aducción, rotación interna y abducción, rotación externa. Vamos a ver el resultado funcional con los movimientos de rango articular amplios que nos han permitido validar que este método es idóneo para fracturas complejas. Entonces, en la discusión vemos que la técnica de MIPO completa helicoidal en fracturas humerales y asfixiadas multifragmentarias con extensión proximal nos permite un respeto biológico a la fractura y nos da resultados clínicos satisfactorios. Versus la Open Reduction and Internal Fixation, existen ventajas, como por ejemplo, una mínima disección quirúrgica, escaso sangrado, infección local reducida y un corto tiempo operatorio. Este método ya es conocido ya hace 2 décadas, o sea, 20 años, pero aún no es considerado como un enfoque principal terapéutico porque se presume un riesgo de lesión neurovascular. Sin embargo, teniendo precaución de estas estructuras, vamos a tener resultados excelentes. El húmero, en su anatomía, la cara lateral proximal es ideal para fijar los tornillos a la cabeza y al cuello. Y en la parte distal anterior anteromedial, la placa se puede adosar en la cara anterior de una manera adecuada al hacerle una forma helicoidal. En el abordaje proximal transdeltoideo y tras colocar la placa helicoidal está en riesgo el nervio axilar y el tendón, la porción larga del bíceps. Pero hay que tener en consideración que el nervio axilar está a 3.5 centímetros de la punta del troquita. Si consideramos ese reparo anatómico, vamos a tener seguridad en nuestro abordaje. Entonces, existe evidencia ya en estudios hechos en hueso sintético y en cadáveres que la placa helicoidal torcida a 90 grados nos permite un respeto del nervio axilar. Que la distancia placa-hueso es mucho menor con la helicoidal versus las fibrorrectas. De manera que una placa helicoidal protege la cabeza larga del bíceps y la inserción deltoidea y permite una elongación más leve del nervio axilar. Entonces, se han hecho estudios biomecánicos comparados a huesos sintéticos, donde se han empleado fuerzas compresivas, rotacionales, axiales, y se ha obtenido un beneficio sustantivo de la placa helicoidal. En el abordaje distal, para el bicipital externo transbraquial anterior, hay que considerar el riesgo de una lesión del nervio cutáneo antebraquial lateral y el radial. Por ello, es menester o necesidad aislarlo para evitar su lesión. Hay que considerar que el nervio músculo cutáneo también puede estar afectado en el transcurso de la placa helicoidal y que hay una zona segura que está de 12.2 a 18.8 centímetros distal al troquíter. De manera que no hay necesidad de aislarlo, sino considerar esta referencia. Recordemos que hay que evitar los tornillos percutáneos porque ponen en riesgo el nervio cutáneo antebraquial en la diáfisis media. Entonces, vemos una imagen donde aplicamos una placa y con el nervio radial adyacente, y hay que considerar que una postura en supinación, rotación externa, nos aleja el nervio radial del implante. Asimismo, hay que respetar el paquete vascular medial de la placa filos al considerar este método. Entonces, considerando estos puntos de referencia, pues el nervio radial, dado su trayectoria peculiar, y la placa debe ir exactamente paralela a este, es que vamos a evitar el riesgo de lesión del nervio radial, ya que la placa filohelicoidal en la porción distal será medial al músculo coracobraquial y debajo del músculo braquial. Entonces, visualizarlo, aislarlo al nervio radial no es necesario. Con ello evitamos una neuropatía. Estudios cadavéricos han demostrado que es seguro evitar del nervio radial en una supinación completa del antebrazo y que se pone aproximadamente a 3.2 milímetros entre el borde del y el nervio radial. De manera que, considerando estos principios, una placa filohelicoidal tiene bajo riesgo de lesión del nervio radial porque es paralela al nervio radial, tanto en la porción proximal como en su porción distal. Tenemos aquí los movimientos seguros rotacionales para evitar un daño en nervio radial. Fíjense que a neutral está relativamente cerca, a rotación interna está muy cerca, pero en rotación externa se aleja de la placa. Entonces, esta es la postura muy segura y recomendada al operar el brazo en rotación externa. Entonces, hay otros estudios por Zamboni donde han hecho estudios biomecánicos donde han torcido una placa helicoidal para fracturas de húmero a 50 grados, 70 y 90 grados, y ellos encuentran una mejor adaptación tanto al troquíter como a la diáfisis distal en una torsión de 70 grados. Entonces, consideramos que hay una ventaja principal de la técnica MIPO en la fijación de fracturas complejas. Esta es una razón importante, pues preserva el hematoma fracturario y respeta los tejidos blandos circundantes, de manera que evitamos unas lesiones de las estructuras neurovasculares que pueden estar en riesgo. Entonces, la placa filohelicoidal en fracturas humerales deficiarias multifragmentarias con extensión proximal nos garantiza una opción eficaz y segura porque protege a las estructuras neurovasculares. Además que preserva la inserción muscular del deltoides, mejora el contacto placa-hueso con un riesgo mínimo de los nervios axilar y radial, además que favorece la curación ósea y mejora el resultado funcional. Thanks.
Well, hello everyone. I know it's been a long journal today, but we're gonna finish with this presentation. My name is William Hibaja. I'm from Peru. I'm a hand surgeon, and now I will talk to you about the SNAC wrist and how to plan your management. This is a literature review. So the objectives of this lecture will include to understand the physiopathology of the SNAC wrist, to learn how to classify it in stages, applying a strategy for each case of these, compare alternatives that are viable, and present some clinical cases as well. Introduction, we will start with this 45-year-old female patient. She's a moderate functional demand teacher that presented in the past 2 years some wrist pain and loss of grip strength. She doesn't refer a specific history of trauma or other treatment received. However, she comes with these x-rays. So what happened here? This is a SNAC wrist, and what is this? Well, our story begins with the scaphoid. The scaphoid bone is a very particular bone. It's very small, it's twisted, surrounded by cartilage. It has a waist, a proximal pole that is somehow difficult to treat or to heal. It has also a particular irrigation that leads the blood flow from the dorsal carpal branches mostly, and some from the volar branches, but this irrigation comes from the distal pole to proximally, leaving the proximal pole with poor irrigation and prompt to non-healing. Plus, if we add another factors that even though when the scaphoid is treated, it has still some percentage of leading to non-union. So if we add up all these factors, that this is a bone that sometimes doesn't even hurt or is very frequently misdiagnosed, or when the proximal pole, or when the treatment has not been enough, or even it has failed, or also when the patient has also some conditions that will lead to non-union, like diabetes or tabacism, then it can add up everything for this bone not to heal. So the next step of this problem would be the scaphoid non-union. When this is diagnosed, you can either treat it with surgery, sometimes you require some bone grafts. When you diagnose this non-union, first you need to look for arthritic changes. If no arthritic changes have occurred, or even if there is some proximal pole necrosis of the scaphoid, you can either treat it with non-vascular bone grafts, you can either fix it with K-wires additionally or screws. Sometimes you can use vascularized bone grafts or even distal vascularized bone grafts like the medial femoral condyle. These are advanced microsurgical techniques for the non-union. However, if arthritic changes do occur, then we are in the next step. This is a SNAC. So SNAC stands for Scaphoid Non-Union Advanced Collapse. The SNAC wrist can have an evolution after 5 to 10 years after non-union, so we should always look for previous history of trauma. The problem with the SNAC wrist is that sometimes it doesn't hurt that much, but the patient can then refer some pain, or occasionally they fall again and they come to the ER, and when we see the x-rays, we find all these arthritic changes in the wrist. So the pictures are necessary x-rays, but we can improve the diagnosis with additional tests like CT scans, MRI, or if available, wrist arthroscopy. There are other forms of advanced collapse. It all starts with the SLAC, which is the scapholunate advanced collapse, but there are other like the SMAC, SCAC, and many other. And why all of these have similar names? Because the progression to arthritic changes are pretty similar between them. So we will see about the physiopathology of the SNAC wrist. This is a wrist. We know that there is an scapholunate angle of 30 to 60 degrees, and the scaphoid is the link from the proximal row to the distal row. There are some ligaments, volarly and dorsally, that can attach these keys. So here I'm marking in blue the scaphoid and in red the lunate. What happens when there is a fracture of the waist of the scaphoid? Then we lose this angle. So the scaphoid flexes. The proximal pole extends because it is still attached to the lunate. And the lunate, since the dorsal ligaments are stronger, it tends to extend, and this is called a DC. So this abnormality in the motion causes the collapse of the distal row, and this leads to arthritic changes. For the SNAC wrist specifically, these arthritic changes can start from the radial styloid and the distal scaphoid, then the scaphocapitate joint, then the lunocapitate joint, and then we can have a diffuse radiocarpal osteoarthritis. So another conclusion of this is that this progression is somewhat predictable. There are classifications that try to determine which stage we're dealing with. The problem with this is that in the 1984, they tried to combine both SNAC and SLAC with this classification defined by Watson. And Bender, some years later, tried to make it more directed to the SNAC, making the exception for the stage 2, which is the scaphocapitate joint compromise. And we will know this importance a little later in this presentation, because it's important, it's key to understand what facets are affected in order to plan the treatment. But what is the problem also with these classifications? If we evaluate some papers, the reliability and reproducibility of X-rays and the kappa ratio between observers is very low. So it's difficult to understand what classification can we add up just by looking at the X-rays. Even with expert hand surgeons, X-rays are not enough for diagnose or the classifications. So we can improve this diagnosis with MRI. It can add up sensitivity up to 62% and specificity up to 97%, which is pretty good. But the arthroscopy, which more and more hand surgeons are being trained to, it can have an important role. But remember, this is a surgery, so it doesn't lack morbidity, but it can look directly to the joints compromise. But if we combine all of these, the CT scan, the MRIs, and the arthroscopy, then we can have a higher correlation in the stages for the treatment. And as we'll say now, the stage classification is extremely important to know. Arthroscopy apparently is the gold standard to evaluate the joints that are compromised. So what can we offer for a patient with the SNAC already established if we have already diagnosed the stage? If it's stage 1, it means that there are few arthritic changes around the scaphoid. So we can either observe if the patient doesn't have much pain, we can denervate the posterior interosseous nerve is an alternative. We can have some radial styloidectomy because it can cause some impingement in the lateral side, or we can treat the scaphoid to as if it was only a non-union. That can be viable. But when we have a stage 2, meaning that there is a spare of the lunocapitate facet, then we can do all these alternatives, but we can choose between these other 2 procedures, which is the proximal row carpectomy or the 4-corner fusion. There is a lot of debate about this that I want also to resolve today. If we have a stage 3, it means that the lunocapitate joint is affected. Therefore, it means that we can no longer provide a proximal row carpectomy, so we can maybe opt for a 4-corner fusion. But when there is a diffuse osteoarthritis, we can either opt for total wrist fusion or total wrist replacement. Just a few words about the stage 1. When we can still spare the scaphoid, we can either treat it as a non-union. Sometimes we can have a viable proximal pole and we can fix this to the next bones. Or if we have a low demanding older patient, sometimes just removing the distal pole may be enough. The problem comes when trying to decide whether or not do a proximal row carpectomy or a 4-corner fusion in a stage 2 or stage 3. It was classically said that proximal row carpectomy would be useful for people with less activity because it can move but loses strength, but the 4-corner fusion with patients with more activity, because even though the patient won't move as much, it will still have more strength as the proximal row carpectomy. But is that so? Well, we will go back to the initial case. Now, this is the patient. We diagnosed it. It was a SNAC grade 2. And we opted for a 4-corner fusion, considering that the patient was young and still high demanding. What is the 4-corner fusion? This is a surgery where we remove the scaphoid, we remove the radial styloid, then we fuse these 4 bones, the lunate, capitate, hamate, and trichitum, and we fix this with a graft, usually opted from the same scaphoid, or we can use autografts or allografts, and we fuse these 4 bones with whatever we have in hand. We can use K-wires, plates, screws, and we'll see a bit more about it. The arthroscopy is an option just to review that the joints are compromised so we can perform a better diagnosis and surgical planning. This can be done openly. We fix these 4 bones, we correct the disease. It's important to align the capitate and the lunate. And this is the patient after the surgery where the fusion has been successful and the joint has kept the alignment between the lunate and the capitate. What happens with these fusions? The range of motion is highly compromised. The patient will only extend just a few 15 degrees to 45 degrees of flexion. The grip strength will be about 65% compared to the other side. but the pain will be in a EV score of 1 or 2. We can also use bone staples. This is a good option. We can use a circular dorsal plate, which is another option, but has some surgical considerations. When the DC is hypocorrected or when it is hypercorrected and we apply the circular plate there, when the patient tries to do extension, it will impinge when it is hypercorrected. So a little trick when you want to use this plate is to hypercorrect the DC, so you decrease the impingement of the plate with the distal radius. This is one frequent option that you find when doing this surgery. But now there exists lower profile plates or better surgical techniques, so this impingement doesn't occur that much. But the screws, I think screws is the preferred method for fixation. The four-corner fusion with screws can be done in different configurations. The important screw is the one that fixes the lunate to the capitate, and it can be done distal to proximal or proximal to distal. This is another patient, also 45-year-old male patient. He's a construction assistant with a SNAC 3, meaning that the joint between the lunate and the capitate has been compromised, and we do this four-corner fusion. The problem with the fusion when you either go proximal or distal is that this screw will either be too marginal on the anterior horn of the lunate if you do from proximal to distal, from distal to proximal, or if you come from proximal to distal, it can be close to the dorsal horn of the scaphoid. So it's very difficult to be exactly on the center of the bone. Again, the range of motion is highly compromised compared to the other side, but the grip strength is somehow acceptable. But what tricks can we understand when using these screws? Well, again, the important step here is to reduce the DC to correct the alignment of the lunate. Then we can flex the joint. We can pass the guide wire and the screw from that. But as you see, it is difficult to make the screw being centered between these two bones, but this is good enough. Another alternative would do the Lynch maneuver, which means passing a K-wire from the distal radius, and then we can pass from the center of the lunate and the capitate and introduce the screw from the distal radius. It will create a small hole in the radius that will probably not lead to high morbidity, but we can have a better alignment of the screw. This is a trick they demonstrated. Another thing that we find is it's debatable whether or not a single screw is enough, 2 screws, if it will be in a single column, in a double column, or if we can have these triangle shaped alternatives. A single column is shown here. Apparently, the most important screw will hold everything together. This will not be a 4-corner fusion, but rather a 2-corner fusion. But apparently, it is still a very good option. We can use smaller screws. We can have a double column as explained by Luquetti and collaborators, and we can provide good fixation and stabilization. And other things that people try to compensate now is do the arthrodesis with the arthroscopy assistance. We know that this is very viable, but it's a very steep learning curve from diagnosis to a full fusion. This is a paper by Dr. Piñal where he shows how the evolution for a 4-corner fusion can be done completely arthroscopically, but this has a very steep learning curve that can lead a surgery that can last up to 4 hours to a single tourniquet time. Very interesting paper. But is it really important? I mean, should we all do arthroscopically? Apparently or theoretically, it will have less stiffness because it is less invasive. The main advantage, I think, is the diagnosis, but for the treatment, apparently it has similar outcomes. So this still needs to have some more follow-up. But what about proximal row carpectomy? There has always been debate between which treatment is better. Proximal row carpectomy consists of removing the 3 proximal bones from of the carpus. So the new joint is made by the distal radius and the proximal capitate. This is an easier procedure. It can still spare some motion more than the fusion, but the main indication is that the joint between the lunate and the capitate is spared. So it cannot be indicated in a stage 3, otherwise you will still connect an arthritic joint with another one, and that will lead to pain and a bad outcome. So when they compared which treatment is better, the problem when we review this literature is that they mix the patients between the stages. So we are reviewing a stage 2 or a stage 3. This is a paper that I like because all the cases were only stage 2. So it was a more homogeneous group. And they compared the proximal row carpectomy and the four-corner fusion. And the outcomes, they demonstrate that they have possibly a better range of motion for the proximal row carpectomy and a better grip strength for the four-corner fusion. But these differences are not too marked, so this is still debatable. The DASH score and the satisfaction rates are similar between them. And if we compare all of these, the numbers are really not so separated apart. So maybe we can include for the proximal row carpectomy for a stage 2. This is another paper comparing also the proximal row carpectomy and the four-corner fusion as a systematic review. Also, they try to make similar demographics, but the problem here is that the proximal row carpectomy and the four-corner fusions also varied many on the indications and the stages. But again, the conclusions are pretty similar. Possibly the proximal row carpectomy have better motion and the four-corner fusion has better strength, but still the differences are minor. They are still both similar in other outcomes. They demonstrate that complications are more for the four-corner fusion, but this is also somehow obvious because we're using material, we're using plates or screws or K-wires. So there are more local reactions than just a proximal row carpectomy. And this is another paper that has this pompous title, The Never-Ending Battle Between Proximal Row Carpectomy and Four-Corner Fusion. Again, it doesn't differentiate between the stages. They had combined the SNAC and the SLAC in the same groups, so this is an insufficient population group. Again, they demonstrate similar outcomes, and possibly the conclusion of this paper is that proximal row carpectomy can be preferred because it's more simpler and it has less complications. But remembering this. And this is another paper also trying to evaluate these techniques. Again, they come to a similar conclusion. So the key point here is patient selection. And for this, the key is to understand what was the stage that we were dealing with the SNAC wrist. So our final messages would be the SNAC is a predictable degenerative pattern of the wrist. We can get as much information possible for surgical planning, so it's extremely important to plan whether or not it's stage 1, 2, 3, or 4. If we have the arthroscopy available, we can use this as a diagnostic tool. We know there is no superior technique, but remember, if the lunocapitate joint is compromised, you can opt for four-corner fusion, providing good materials, of course. If we set a stage 2, maybe the proximal row carpectomy would be the best choice. So it's all about patient selection and the prognosis. Thank you so much for your attention. I'm William Gibaja from Peru.